everybody. This is Lori Jean. I'm here with Erin Marie RN on Facebook and SaraNP on Facebook. So we're here to chat with you guys today about COVID and some interesting information, some bombshell information that we just got, which is unverifiable and actually has already been deleted, but we were on top of it and shared it with each other and decided it was really important to share. So we're going to give you guys some really exciting new type of information to think about this in a little bit of a different way. The first thing we're going to do is share a video. I'm going to share my screen so you guys can see a video, and it's from a doctor in New York City who's doing an ICU hospital there, and he is usually an ER doctor for years and years, but they've asked him to set up this ICU, and he's been bedside for 9 days, 10 days now with these patients. And he has some really interesting outlook. And so I just want to make sure that we show you kind of where we started with this and then how it seems to be progressing down his line of thinking. And that's been backed both by what he has seen in New York and then other practitioners in Italy have seen too, which he has been discussing with the Italians. So it's really interesting. He also has a blog and a podcast, which we can link later. But I'm going to go ahead and share his video. And that's kind of where we got started with this theory. So without further ado, let me pull up my desktop and get him on the screen. Okay. Let's share this real quick.
Guided treatment will lead to a tremendous...
Hang on just one second.
And progressively...
Okay.
This is Dr. Cameron Kyle-Sidell, ER and critical care doctor from New York City. 9 days ago, I opened an intensive care unit to care for the sickest COVID positive patients in this city. In these 9 days, I have seen things I have never seen before. In treating these patients, I have witnessed medical phenomenon that just don't make sense in the context of treating a disease that is supposed to be a viral pneumonia. 9 days ago, I presumed I was opening an intensive care unit to treat patients with a virus causing a pneumonia that was ravaging lungs across the world, starting out as something mild, cough, a sore throat, and progressively increasing in severity until ultimately ending in something called acute respiratory distress syndrome, or ARDS. This is the paradigm that every hospital in the country is working under. This is the disease, ARDS, that every hospital is preparing to treat. And this is the disease, ARDS, for which in the next 2 to 6 weeks, 100,000 Americans might be put on a ventilator. And yet, everything I've seen in the last 9 days, all the things that just don't make sense, the patients I'm seeing in front of me, the lungs I'm trying to improve, have led me to believe that COVID-19 is not this disease, and that we are operating under a medical paradigm that is untrue. In short, I believe we are treating the wrong disease, and I fear that this misguided treatment will lead to a tremendous amount of harm to a great number of people in a very short time. As New York City appears to be about 10 days ahead of the country, I feel compelled to get this information out. COVID-19 lung disease, as far as I can see, is not a pneumonia and should not be treated as one. Rather, it appears as if some kind of viral induced disease, most resembling high altitude sickness. It is as if tens of thousands of my fellow New Yorkers are on a plane at 30,000 feet and the cabin pressure is slowly being let out. These patients are slowly being starved of oxygen. I have seen patients dependent on oxygen take off their oxygen and quickly progress through a state of anxiety and emotional distress and eventually get blue in the face. And while they look like patients absolutely on the brink of death, they do not look like patients dying of pneumonia. I have never been a mountain climber, and I do not know the conditions at base camp below the highest peaks in the world. But I suspect that the patients I'm seeing in front of me look most like as if a person was dropped off on the top of Mount Everest without time to acclimate. I don't know the final answer of this disease, but I'm quite sure that a ventilator is not it. That is not to say that we don't need ventilators. We absolutely need them. They are the only way at this time that we're able to give a little more oxygen to patients who need it. But when we treat people with ARDS, we typically use ventilators to treat what's called respiratory failure. That is, we use the ventilator to do the work that the patient's muscles can no longer do because they're too tired to do it. These patients' muscles work fine. I fear that if we're using a false paradigm to treat a new disease, that the method that we program the ventilator one based on a notion of respiratory failure as opposed to oxygen failure, that this method, and there are a great many number of methods we can use with the ventilator, but this method being widely adopted at this very moment in every hospital in the country, which aims to increase pressure on the lungs in order to open them up, is actually doing more harm than good. And that the pressure we are providing, to lungs, we may be providing to lungs that cannot stand it, that cannot take it. And that the ARDS that we are seeing, that the whole world is seeing, may be nothing more than lung injury caused by the ventilator. Now, I don't know the final answer to this disease. I do sense that we will have to use ventilators. We will have to use a great many number of ventilators, and we need a great many number of ventilators, but I sense that we can use them in a much safer way, in a much safer method. That safer method challenges long-held dogmatic beliefs within the medical community and among lung specialists, which will not be easy to overcome. But I really believe that they must be overcome. There are hundreds of thousands of lungs in this country at risk, and the time to overcome them is now. I'm confident that if those of us that work bedside with these patients, those of us who are witnessing the things that we have never seen before, despite the many years we have worked and the thousands of patients and diseases we have seen, if we can effectively communicate this to all those that are so important but who are not bedside, the researchers, the administrators, those who procure our resources and make our protocols, the politicians, our own governments, if we are able to convince them that this is a disease that is different than anything we have ever seen, I'm confident that an answer can be found, that effective treatments can be discovered, and that a plan to disseminate that treatment can be rapidly deployed, and that tens of thousands and probably hundreds of thousands of lives and lungs will be protected. The time for this is now. We are staring into a future in which a great many of our fellow Americans are going to suffer, not to mention people all around the world. For those who will not suffer directly from this disease, from the terrible human cost of this disease, for those who will not lose a family member or a friend, and there will be a great many number of people who will lose those close to them. But for those who don't, they are still going to suffer from the great economic cost of COVID-19. We are all involved in this future. So I urge you, for those of us, if you are out there, for those who work bedside, I urge you to speak up. We can change this. I thank you all for listening. Please spread the message and stay safe.
Okay, so that's how we came up with this. And he is still posting. This was a couple of days ago that I posted that. So he has had some up-to-date information. He has a podcast of 20 minutes and some links to follow and things like that. He's on Twitter. We can follow him. And he says his name. We can also post his link later. But he has a lot of really good ideas. And then some people have thought through his line of thinking a little further and kind of elaborated on it in this awesome, I want to call it an article. Is that right? Yeah, like an article that Sarah sent over to us. So we've been chatting about it. And so COVID, y'all. We're going to read the article to you guys because we can't say it any better than the article does. But we just wanted to kind of talk a little bit about our thoughts, like, you know, whether or not we think this is natural, man-made, maybe some of the stuff we were chatting about right before we got on live, and just chat, and then we can read it to them. Does that sound good?
Sounds good.
So what is everybody's thoughts? What do y'all think?
Sarah, you want to go?
Okay. So before we get started with the article, I want to just put it out there that this is not, the source is not verified. We don't know who this Maven person is that posted this article. It's on a few different social media platforms. People were able to screenshot it and archive it so that it can be shareable, but that original post, I understand, is no longer there. To me, it's that much more intriguing because nothing about COVID is clear. Like COVID-19 this whole time has been a mystery. Everything about it is a mystery. People on the front lines are saying, I've never seen anything like this before, including this doctor. If you have any friends that are nurses, CNAs, lab techs, respiratory therapists, nobody has seen anything like this before. I wouldn't be surprised if this person who has written this article doesn't want to be in the spotlight like Dr. Sidell, maybe they don't want any of that. They're just putting this out there to ring the alarms. And our job, what the three of us have always done, in my opinion, is that we're messengers. We have a really important message to spread. I myself, I'll tell you right now, I'm not on the front lines right now. I have plenty of friends who are, and everybody's saying something similar. Never seen anything like this before. There are a few hallmarks of the patients who are dying with this disease that are really unmistakable, things that we're seeing over and over again. So we were talking about this as we were discussing before we went live. These patients, they're really rapidly declining. They do not present like a viral pneumonia, like this doctor just said in the video. They're hypercoagulable, and when you read this article, you'll understand why that is. The way that their labs are trending, these things just don't appear to be a typical viral pneumonia. So to call COVID-19 a viral pneumonia and treat it that way, it doesn't make any sense. Like, why are we treating it like this? So once we read this article, and certainly anybody that's a clinician will be able to appreciate this. And from what I saw just on the boards of people's reactions to this article, people think it's some kind of, whatever the terms are, like it's some kind of a shill, or it's some kind of opposition or something like that. But clinicians are saying, hey, this kind of seems to make sense. I don't know who wrote this article, but it looks it could be what's happening with all these patients. So we know that this week is supposed to be the worst week. I mean, that's what we're being told by the news. So if you or a loved one or someone you work with, someone you know, is starting to present with symptoms, this is information that you are going to want to know, like, immediately. A few weeks ago, I think all of us were even wondering, like, is this thing real? Is this even a virus? What's going on? And then as people were starting to speak up in the hard hit cities saying something is going on here, we don't know what it is, but this is people are definitely dying. This thing is evolving every single day. Now we're at the point where we know something is happening. We don't even know what it is, but so far this seems like the most plausible theory.
Yeah, I definitely. What do you think, Erin?
I just hope that everyone can be able to look at this with an open mind, because we don't know. Nobody knows. So I guess we're all nurses here. Like, we're trained to be able to think critically and look at the big picture and understand that, science is never settled. This obviously isn't settled, but there are some really good points that have been made, and they just kind of make sense. So I don't think that what they're doing right now as far as treatment, it's obviously not working. And, that's what you hear, like, I don't know what to do. We don't know how to treat it. I'm floating around into the emergency department right now. The doctors there don't really know, and they admit it. We don't really know what's going on. So something like this is really good to be able to hang on to and, just comb through it and really take a look at it, because this could be a game changer. So I think that's why we're all here. We just kind of want to put the information out there, make sure it gets heard, and people can, hopefully share this with some, pretty intelligent, doctors, chemists, scientists out there that, may not ever cross their desk.
Absolutely.
Sorry, go ahead.
No, go ahead.
Just from his video, I was going to say, just some thoughts, like he was saying that we could be causing injury. I don't know if you guys are, like, people don't know ventilators. And since I just did my rounds in ICU and everything, ventilators, they have what's called a PEEP setting. And PEEP just means you're basically going to take this alveoli, and theoretically in pneumonia or something like that, the alveoli is where the gas exchange happens, where you drop off the oxygen and you pick up gas, and you're going to expel the gas, and you're going to get the oxygen to the tissue. Okay, so PEEP just tells the alveoli, if they're collapsed, if they're like on top of each other, and you're not able to get it open, PEEP is like an extra puff of air almost. It's like a way to open the alveoli. So the sacs are closed theoretically, and this is probably not what's happening in COVID. This is what would happen in pneumonia. But theoretically, they would be like this, and we're going to give a PEEP, which is a puff, and we're going to try to open that sac. And if we're opening the sac, in a collapsed alveoli, that would be great, right, to try to help. However, if the settings were too high, or if that sac actually isn't on top of each other, then we could be overflowing them, and that could be causing injury. That is what he's saying.
So that
we're
is
not
a ventilator-induced lung injury. You can actually cause ARDS by use of the ventilator in a situation where it's not appropriate or using inappropriate pressures. So if we're treating these people, like if we're looking at these patients, like they need that oxygen exchange, they're not able to do it themselves because of their lungs, and they're using the ventilator to do that work, they're going to blow those lungs open. I mean, just in layman's terms, they're gonna harm that tissue. When we're reading now and we're getting these accounts from people on the front lines, that it's not that their lungs aren't able to do the work, and it's not the alveoli really, it's that their cells can't carry oxygen, and so the lung injury is actually secondary
to a blood injury, essentially.
something that's going on in the blood system wide.
Mm-hmm.
What we think for sure. And we think that it could be that we are, causing the harm, and that the PEEP settings maybe should be lower. That's what he's saying, is like they may be needing a vent because these people might be choking on secretions. They might not be able to maintain an airway, right? So he's not saying don't ventilate. He's just saying, if we ventilate, how should we be ventilating? Should we be ventilating the same old way we always do it? Or should we think about things like maybe they can do the work, but the problem is oxygen? And he even was saying in his 20-minute video that the oxygenation should, I mean, he wishes we could go way higher than 100% FiO2. He wishes we could go 200, 300%, because these people need like hyperbaric oxygen chambers. You know, they need as much oxygen as possible. So that's why he said he can ride his patients on high flow oxygen until they can't do it anymore. And then he has to vent them because they can't do it. But he's saying he's having some success, whereas like instead of intubating and being on a vent like 9, 12, 15 days, he can ride them on high flow, get as much oxygenation in them as possible, and then be able to intubate for a shorter amount of time, and then low PEEP settings, high FiO2, and hopefully that is, able to help. But yes, if there's a blood problem,
at least that in that case, that the ventilator is not the default.
Yes, or at least, in the beginning, right? Like try to give them as much. What they need is not necessarily what we always thought, respiration issue, right? It's an oxygenation issue. This is
right. So this is being currently, as he states, is being treated wrong. We're treating the wrong disease.
Yes, absolutely. And we love this article, so we're going to get to reading it because it's really good, important information. And we'll have Sarah start with me if you want to. Oh, hang on just one second. Let me get it up for everybody. I forgot I'm not sharing my screen. Let me put it up for you guys so you can read along with us. And we'll post this somehow. So here we go.
All right. In the last 3 to 5 days, a mountain of anecdotal evidence has come out of New York City, Italy, Spain, etc., about COVID-19 and characteristics of patients who get seriously ill. It's not only piling up, but now leading to a general field-level consensus backed up by a few previously little-known studies that we've had it all wrong the whole time. Well, a few had some things eerily correct, cough, Trump cough, especially with hydroxychloroquine, with azithromycin, but we'll get to that in a minute. There's no pneumonia nor ARDS, at least not the ARDS, ARDS, with established treatment protocols and procedures we're familiar with. Ventilators are not only the wrong solution, but high pressure intubation can actually wind up causing more damage than without, not to mention complications from tracheal scarring and ulcers given the duration of intubation often required. They may still have a use in the immediate future for patients too far to bring back with this newfound knowledge, but moving forward, a new treatment protocol needs to be established so we stop treating patients for the wrong disease. The past 48 hours or so have seen a huge revelation. COVID-19 causes prolonged and progressive hypoxia, starving your body of oxygen by binding to the heme groups in hemoglobin in your red blood cells. People are simply desaturating, losing O2 in their blood, and that's what's eventually leading to organ failure that kills them, not any form of ARDS or pneumonia. All the damage to the lungs you see in CT scans are from the release of oxidative iron from the hemes. This overwhelms the natural defenses against pulmonary oxidative stress and causes that nice, always bilateral ground glass opacity in the lungs. Patients returning for rehospitalization days or weeks after recovery, suffering from apparent delayed post-hypoxic leukoencephalopathy, strengthen the notion that COVID-19 patients are suffering from hypoxia despite no signs of respiratory tire out or fatigue. Here's a breakdown of the whole process, including some Eli 5-level cliff notes. Much has been simplified just to keep it digestible and layman friendly. Your red blood cells carry oxygen from your lungs to all your organs and the rest of your body. Red blood cells can do this thanks to hemoglobin, which is a protein consisting of 4 hemes. Hemes have a special kind of iron ion, which is normally quite toxic in its free form, locked away in its center with a porphyrin acting as its container. In this way, the iron ion can be caged and carried around safely by the hemoglobin, but used to bind to oxygen when it gets to your lungs. When the red blood cells gets to the alveoli, or the little sac in your lungs where all the gas exchange happens, that special little iron ion can flip between Fe2 and Fe3 states with electron exchange and bond to some oxygen, then goes off on its little merry way to deliver O2 elsewhere. Here's where COVID-19 comes in. Its glycoproteins bond to the heme, and in doing so, that special and toxic oxidative iron ion is disassociated or released. It's basically let out of the cage and now freely roaming around on its own. And this is bad news for 2 reasons. Without the iron ion, hemoglobin can no longer bind to oxygen. Once all the hemoglobin is impaired, the red blood cell is essentially turned into a Freightliner truck cab with no trailer and no ability to store its cargo. It is useless and just running around with COVID-19 virus attached to its porphyrin. All these useless trucks running around not delivering oxygen is what starts to lead to desaturation or watching the patient's SpO2 levels drop. It is incorrect to assume traditional ARDS, and in doing so, you're treating the wrong disease. Think of it a lot like carbon monoxide poisoning, in which carbon monoxide is bound to the hemoglobin, making it unable to carry oxygen. In those cases, ventilators aren't treating the root cause. The patient's lungs aren't tiring out. They're pumping just fine. The red blood cells just can't carry oxygen. End of story. Only in this case, unlike carbon monoxide poisoning, in which eventually the carbon monoxide can break off, the affected hemoglobin is permanently stripped of its ability to carry oxygen because it has lost its iron ion. The body compensates for this lack of O2 carrying capacity and deliveries by having your kidneys release hormones like erythropoietin, which tells your bone marrow factories to ramp up production of new red blood cells with freshly made and fully functioning hemoglobin. This is the reason you find elevated hemoglobin or ferritin and decreased blood oxygen saturations as one of the 3 primary indicators of whether the you-know-what is about to hit the fan for a particular patient or not. Secondly, that little iron ion, along with millions of its friends released from other hemes, are now floating throughout the body freely. As I mentioned before, this type of iron ion is highly reactive and causes oxidative damage. And just a side note here, I kind of wonder if this is why children are doing better, because they're able to cope with the oxidative stress better, because as we age, we know that we have more oxidative damage and we're not able to deal with that as well. Anyway, back to this. It turns out that this happens to a limited extent naturally in our bodies, and we have cleanup and defense mechanisms to keep the balance. The lungs in particular have 3 primary defenses to maintain iron homeostasis, 2 of which are in the alveoli, those little sacs in your lungs we talked about earlier. The first of the 2 are little macrophages that roam around and scavenge up any free radicals like this oxidative iron. The second is a lining on the walls called the epithelial surface, which has a thin layer of fluid packed with high levels of antioxidant molecules, things like ascorbic acid, aka vitamin C, among others. Well, this is usually good enough for naturally occurring rogue iron ions, but with COVID-19 running rampant, your body is now basically like a progressive state, letting out all the prisoners out of the prison, and it's just too much iron, and it begins to overwhelm your lungs countermeasures, and thus begins the process of pulmonary oxidative stress. This leads to damage and inflammation, which leads to all that nasty stuff and damage you see in the CT scans of COVID-19 patient lungs. Ever notice how it's always bilateral, both lungs at the same time? Pneumonia rarely ever does that, but COVID-19 does every single time. Once your body is now running out of control with all your oxygen trucks running around without any freight and tons of this toxic form of iron floating around in your bloodstream, other defenses kick in. While your lungs are busy with all this oxidative stress they can't handle and your organs are being starved of O2 without their constant stream of deliveries from red blood cells hemoglobin, and your liver is attempting to do its best to remove the iron and store it in its iron vault. Only it's getting overwhelmed too. It's starved for oxygen and fighting a losing battle from all your hemoglobin letting its iron free, and starts crying out, help, I'm taking damage, by releasing an enzyme called alanine aminotransferase, or ALT. Boom, there's your second of 3 primary indicators of whether the you-know-what is about to hit the fan for a particular patient or not. Eventually, if the patient's immune system doesn't fight off the virus in time before their blood oxygen saturation drops too low, ventilator or no ventilator, organs start shutting down. No fuel, no work. The only way to even try to keep them going is max oxygen, even a hyperbaric chamber if one is available, on 100% oxygen at multiple atmospheres of pressure, just to give what's left of their functioning hemoglobin a chance to carry enough O2 to the organs and keep them alive. Yeah, we don't have nearly enough of those chambers, so some fresh red blood cells with normal hemoglobin in the form of transfusion will have to do. And if you remember, some people were saying at the whole start of this, there was this whole, the core point being treating patients with the iron ion stripped from their hemoglobin, rendering it abnormally non-functional with ventilator intubation is futile, unless you're just hoping the patient's immune system will work its magic in time. The root of the illness needs to be addressed. Best case scenario, treatment regimen early before symptoms progress too far. Hydroxychloroquine, more on that in a minute, I promise, with azithromycin has shown fantastic, albeit critics keep mentioning anecdotal, to describe the mountain. Promise and explain why it does so well next. But forget straight up plasma with antibodies. That might work early, but if the patient is too far gone, they'll need more. They'll need all the blood, antibodies and red blood cells. No help in sending over a detachment of ammunition to a soldier already unconscious and bleeding out on the battlefield. You need to send that ammo along with some hemoglobin stimulant magic so that he can wake up and fire those shots at the enemy. So what's the story with the hydroxychloroquine? All that hilariously misguided and counterproductive criticism the media piled on chloroquine, purely for political reasons, as a viable treatment will now go down as the biggest fake news blunder to rule them all. The media actively engaged their activism to fight bad orange man at the cost of thousands of lives. Shame on them. How does chloroquine work? Same way as it does for malaria. You see, malaria is this little parasite that enters the red blood cells and starts eating hemoglobin as its food source. The reason chloroquine works for malaria is the same reason it works for COVID-19. While not fully understood, it's suspected to bind to DNA and interfere with the ability to work magic on hemoglobin. The same mechanism that stops malaria from getting its hands on hemoglobin and gobbling it up seems to do the same to COVID-19. Essentially, little snippets of DNA in an envelope from binding to it. On top of that, hydroxychloroquine, an advanced descendant of regular old chloroquine, lowers the pH, which can interfere with the replication of the virus. Again, while the full details are not known, the entire premise of this potentially game-changing treatment is to prevent hemoglobin from being interfered with, whether due to malaria or COVID-19. No longer can the media and armchair pseudo-physicians sit in their little ivory towers proclaiming, "Durr, so stupid, malaria is bacteria, COVID-19 is a virus, antibacteria drug no work on virus." They never got the memo that a drug doesn't need to directly act on the pathogen to be effective. Sometimes it's enough just to stop it from doing what it does to hemoglobin, regardless of the means it uses to do so. Anyway, enough of the rant. What's the end result here? First, the ventilator emergency needs to be re-examined. If you're putting a patient on a ventilator because they're going into a coma and need mechanical breathing to stay alive, okay, we get it. Give them time for their immune system to pull through. But if they're conscious, alert, compliant, keep them on O2. Max it if you have to. If you have to inevitably ventilate, do it at a low pressure, but max O2. Don't tear up their lungs with max PEEP. You're doing more harm to the patient because you're treating the wrong disease. Ideally, some forms of treatment need to happen. Inhibit viral growth and replication. Here plays the hydroxychloroquine, the Z-Pak, and the zinc, or other retroviral therapies being studied. Less virus, less hemoglobin losing its iron, and less severity and damage. Therapies used for anyone with abnormal hemoglobin or malfunctioning red blood cells. Blood transfusion, whatever. I don't know the full breadth and scope because I'm not a physician, this person says. But think along those lines and treat the real disease. If you're thinking about giving them plasma with antibodies, maybe if they're already in bad shape, think again and give them blood with antibodies, or at least blood followed by plasma with antibodies. Now that we know more about how this virus works and affects our bodies, a whole range of options should open up. And number 4, don't trust China. They covered this up and have caused all kinds of death and carnage, both literal and economic. The ripples of this pandemic will be felt for decades.
Fini. So they're Italian. Okay. Yeah, awesome article. One thing just as a very big precursor is when I was just working ICU not too long ago, we were always out of blood. I mean, they have a national blood shortage, you guys. This is no joke. Okay, so always, I mean, it's all the time, but especially right now. So they are begging for blood, and the blood banks are open. So I'm going to ask every one of y'all to please go and donate blood. And one of the reasons is because they're going to need it for this. It seems like one of the only solutions besides hydroxychloroquine, chloroquine, and some of these other things we've got going on, but they're going to need the red blood cells. So a lot of times we were thinking they would need the plasma, right? They would need the antibodies from the people who were previously infected, but that's not even the issue. The issue is they need full red blood cells. They need the whole schmo. They need the whole packed RBCs.
So I even wonder, I shared on my wall a few days ago a video from a Dr. Wong, and he was explaining the pathology of COVID-19 and saying that the virus attacks AT2 cells, or alveolar type 2 lung cells, and that this is those cells are responsible for like production of surfactant, and that's why the lungs are clogging up, and that's more of like what we would see in a viral pneumonia. But this is a totally different theory of the pathology of COVID-19. And there's another, I received something else from somebody that that is along the same lines as this, and I'd like to share it because it's just seeing the same things, but using a computational analysis. So using computational analysis, modeling the behavior of a molecule in a computer, they've worked out the probable mechanism by which SARS-CoV-2 wreaks havoc. That's COVID-19. COVID-19 is the disease from this virus, SARS-CoV-2 virus, wreaks havoc on patients, as well as why chloroquine and favipiravir, an antiviral, seem to work. Inside our red blood cells, there is a molecule called hemoglobin, which contains a heme group. Each heme group is a molecular ring called a porphyrin, which can hold an iron, Fe ion inside. Having an iron ion inside is what allows this heme to carry oxygen and CO2 in our blood. This is how our bodies move oxygen to our tissues and remove CO2 waste products. The paper modeled these and found that the proteins produced by COVID replicates collaborate to knock iron ions out of the heme group and replace them with one of the proteins. And this makes the red blood cell unable to transport oxygen and CO2. If the computer modeling is right, it shows that the virus hijacks our red blood cells and makes it unable to carry oxygen to a patient's tissues and organs, and likewise unable to carry carbon dioxide out of them. This would lead to organ and tissue death, roughly in the same way as if a patient were being suffocated. Even when a patient can breathe, fill the lungs with air, the oxygen isn't getting to the cells in their body. The inflammation in the lungs results from the lungs not being able to perform the oxygen and CO2 exchange, and would therefore appear to be a secondary result of the hijacking of the blood. The lungs not working is a result of lack of oxygen in the blood, not the cause of it, hence the ground glass opacities. The paper models the behavior of chloroquine and favipiravir as well, which appear to bind to the non-structural viral proteins that hijack the heme group, thus inhibiting them from knocking out the iron and wrecking the O2 carrying ability of the red blood cells. This also explains the observation made by various ER docs that the patients tend to have elevated ferritin. Ferritin is used to store excess iron. If a lot of iron is knocked out of the heme group and floating around, the body produces more ferritin. If this is true, it means a few things. Starting drug treatment while symptoms are mild keeps the virus from hijacking too much blood, enabling a still healthy body to mount an immune response. Explains why early drug treatment, first week of symptoms, is often successful. Drug treatment and intubation once patient is critical will rarely work because tissues and organs are already damaged. Blood cannot carry oxygen and the body is too weak to produce new red blood cells able to carry iron and thus oxygen and carbon dioxide, even if the drugs inhibit more hijacking. And 3, start severe patients on drug treatment upon hospital intakes to suppress further hijacking of blood by the virus, then give them a blood transfusion of new red blood cells immediately that are unhijacked. If all this is true, we would see rapid patient improvement. The problem is we have not yet had studies testing whether the patients will respond well to blood transfusions from people who have not had COVID-19. Right now, medical attention is focused on blood transfusions from those who have beat COVID-19 and have antibodies. This needs to be looked at. This research ties into the fact that weight, age, and high blood pressure are such risk factors and why certain blood types are less afflicted than others. So non-African malaria risk zones have a population with genetic thalassemia, which would explain the discrepancies in the population affected by coronavirus noted Italy. So this is saying that in Italy, they had really high morbidity and mortality because genetically that Italian population, they have more incidence of thalassemia, a hereditary disease of the red blood cells, and anemia and oxygenation and all that. So which makes perfect sense. And then another characteristic that we were discussing is that these patients tend to be hypercoagulable. So they're presenting with embolism. So when you have, their blood is sticky because their body is trying to compensate by producing more hemoglobin, more ferritin, and so it's making them clot. And that's something that sometimes we see anyway in the ICU. Trying to piece all this together because this is novel. Is this a phenomena that we see because of everything that's all the risk factors for it anyway when people are intubated in ICU, or is this from the disease process? Is this part of the disease process?
Interesting. I definitely have seen African Americans have a high rate of mortality with this as well. And it's interesting because I thought maybe it had to do with their hypertension, maybe it had to do with that they're often on, ARBs, or maybe they're on, calcium channel blockers, just all kinds of things, like how it affects ACE2. So it's just some interesting things. I love that article though. You should send that to me. I think I've read it, but I didn't get it from you, but yeah, send that to me because I like it. He's got a lot of good things to say too. This is definitely still a mystery, but I think we're starting to unlock a lot of things. This makes a lot of sense. These people are oxygen starved.
They are. And if you, even the videos of patients of taking video of themselves, and maybe, gosh, anybody on the internet right now who has seen a video of a COVID patient recording themselves, they are oxygen hungry. This is what they're panting like they have like elevation sickness, just like Dr. Sidell was saying. Their lungs are working fine. Their lungs might even be clear, but they're not able to oxygenate because their cells can't carry it.
Not that their lungs are fine, because they obviously have an issue.
Right.
It's not that they sound
It's
fine.
not primary. It's not the primary. Yes.
So the hydroxychloroquine, so I was not a fan of that at first because I didn't understand it. I didn't understand why they were going to use that to treat a virus. It made no sense to me. But now being able to look into this, this COVID-19, it seems to be attacking the red blood cells similar to how malaria does. It's almost like a parasite entering the red blood cells, and it's eating the hemoglobin. It's using that as its food source, and it's ultimately it's kicking the iron out, and it's creating ultimately a storm. So this hydroxychloroquine is entering it, and it's almost it's binding to this DNA and being able to give it a little bit of relief. So
it's an envelope, right? It's like enveloping it.
So it's like it's a mother protecting its child, and it's allowing that oxygen to continue. And but I think obviously with the azithromycin, I'm not sure how that is. Maybe it's more a preventative treatment, so they don't develop into a bacterial infection. But eating my words from what I said before, like now looking at it from a different perspective and understanding this a little bit more, it makes perfect sense. And I do think that it really does need to be looked into. And I think maybe even an earlier treatment would be a very good approach.
This is evolving. When you say, I didn't have good feelings about the hydroxychloroquine to begin with. Going back a few weeks ago, things were even more unclear than they are now. We're slowly starting to put some puzzle pieces together. And thank goodness for the people on the front lines who are reporting back to everybody, I've never seen this before. This is what we're seeing. And so many minds are having to come together from all over the world to figure this thing out. And it is evolving. And so, where we were a few weeks ago, we're in a totally different place now. And this is what a novel disease looks like. I mean, for all the lay people watching, this is what a novel disease looks like. We have no idea what we're dealing with. And anybody that I talk to on the front lines, they all say the same thing. It's scary.
Yep.
It's scary because we don't even know. We are flying blind. So look,
Yeah,
if
one of my friends lost
hydroxychloroquine,
3 patients her last shift. She's like, I lost 3 patients. I'm like, oh my gosh, like that never happens. You know, it's like you might lose a patient, but like 3 patients on one shift is rough. I mean, that's,
But are they doing wrong?
why? What did you do wrong?
Yeah, what are we doing wrong? So I think that with this information and, you know, just more information coming in from, you know, the ICUs and the ERs and the people around the world sharing their experiences, and I would hope that more would not be so afraid to do so, because we prevent this, and we can do that by putting all of our minds together and really, you know, sitting here doing what we're doing and just kind of discussing it. And this will create even more people, you know, thinking and being like, you know what, I've had that, you know, this is, you know, something that happened to me, you know, maybe this could be it. And I'd be happy to look into it. We all would be. So I think that hopefully this will lead to bigger things and better treatments and ultimately saving a lot of lives.
absolutely. It's interesting too. I did a little look up on zinc too, because I forgot it's a cofactor. So it actually helps in metabolism of iron. So it totally makes sense why they need zinc, because it's like, it's going to help absorb some of that iron. It's going to help digest it. And I'm like, that totally makes sense. So zinc, yeah, like absolutely. And then just the fact that iron plays a role in coagulation, right? So so much of this makes a lot of sense, you guys. I hope if you're a medical professional that you're paying a lot of attention.
So I shared also a video, an article about Dr. Vladimir Zelenko, New York City, who is having a lot of success with the hydroxychloroquine, the Zithromax, and azithromycin. That's the name for azithromycin, and zinc. And although this is anecdotal, right? That's what they're saying. This is anecdotal evidence that these people are getting better with this drug regimen. Hello, like we're not going to be able to pick up the pieces until later, right? So once this is all said and done, once COVID-19 passes and the biggest immediate threat is over, we're going to obviously go back and look at the data and try to analyze this and learn from it. But in the meantime, like tonight, there are people dying from this. Tomorrow, more people are going to die from this. So if you can get this anecdotal information out to who, maybe it's a doctor that you work with, a nurse, a CNA, a respiratory therapist that's going to go to work tomorrow and share it with somebody else, spread the information, because we don't know what although I'm not actually in the hospital right now, don't know what we are doing. We are taking best guesses. And there's something to be said for, you know, anecdote at this point. And we could like get into that another day, but basically making observations about something that you're seeing. And that's like where science begins, is with observation and a question.
Yep.
Absolutely. And just on his Twitter, you guys, if you follow him, his name is @Cameron, CAMERONKS. So it's @Cameron KS. And his name's Cameron Kyle-Sidell. And so if you go on there, you'll see he's tweeting with all of these people from Italy and all these people, and it's incredible to watch. And they'll show pictures like, here's what my, you know, patient's lungs look like, and here's what's going on, and here's what I'm seeing, and I think you're right. Or, you know, they'll might tweak some of things he's saying and kind of add to it or whatever. It's really cool, and that's what we need to be doing right now in our profession, is just to say, hey, we don't know everything. And a lot of people who have been doing this for 35 years are stumped. They're literally like looking at these people and they say, I've done ICU 35 years and I've never seen this before. And, you know, so we have to be willing to, like you said, treat the patient, look at the patient, figure out what's going on. Like, does it make sense to continue just the same old, you know, ARDS, you know, whatever we thought, or like change things up to see if it's helping patients? And he said he's having some success, just like trying hydrochloroquine and all these other things have produced success. So, you know, we need to be after those governors who are preventing it. Like, we cannot be, you know, those governors that are saying, oh, we won't participate in those kind of treatments. I mean, I sure hope, I think Trump might have put a stop to that. I don't know. Somebody had told me that.
They need to see this video. That's what they need to do. They need
Absolutely.
to sit down and listen.
Also, and it's this video seems to be getting a lot of attention, but how many doctors at this point are treating COVID-19 patients, and any of them should be able to say, well, gosh, I've treated viral pneumonia I don't know how many times. This just doesn't look anything like viral pneumonia.
I know, and that's another thing. It kind of pisses me off a little bit, I'm not going to lie, because people keep telling me, well, this is just pneumonia. This is just the flu. And it's like, if you have friends on the front lines, I can promise you, we have seen it 1,000 times. We have seen thousands of patients with flu. I have seen thousands of patients, like with pneumonia, like so we're used to seeing that. When somebody stops and says, I have never seen this before. Now maybe like, I get it, because I've only been doing this for so long, but like people who've been doing this 30 years, they've never seen patients like this. That should stop people to be like, okay, this isn't the same old thing. No, we're not confusing it. It's not a confusion. This is obviously an oxygenation issue. Hypoxemia means they're breathing in, but they can't get the oxygen to the tissue. So that's why it's causing MODS, which is multiple organ failure. Okay, and that's what's killing these people, is because the tissues, basically when your body is starved of oxygen, like the first thing that's going to go is they're going to start to act confused, because like the brain's going to be like, whoa, what are we doing? But also their fingers and their toes are going to start to get cold. They're going to like look, perfusion isn't going to be as good, because they're going to be like, what's going on? The oxygen isn't making it to those tissues. They're trying to save it for the heart, lung, kidneys, and that's why the kidneys start to go. That's why in the clinical signs in this article, right, the first sign was elevated hemoglobin. The second sign was elevated ALT. And then the third sign, I didn't actually catch, what was that third sign? Does anybody have that off the top?
The other thing that he talked about is the way that the lungs look on imaging.
Yeah, the opacities. Okay, yeah. And they're bilateral, which is uncommon. I mean, this isn't something in pneumonia that's always bilateral. It's usually one or the other. So this is every single time, without fail, always bilateral. So these are the things that we clinically can be looking for. Elevated hemoglobin, elevated ALT, the liver's going to go. Like, you just know, AST, ALT, and opacities in both sides bilaterally. But yeah, so hopefully you guys will share this message. This is really important to continue having conversations like this. And as we get more information, we'll probably just keep chatting, because I think this is great. Yeah. And two heads are better than one, right? So do you guys have anything else you want to say? Yeah, right. Well, I'm kind of like half, so.
No, that was awesome. I think let's keep an open discussion, and just try to, I don't know, comb through everything with an open mind, because nobody knows. And if
nobody knows. This might not be it, but we don't know what it is. So,
but it does make sense, and I think we're headed towards a good track to try, right? Because they're already trying something that's not working. So like, what's the harm in trying something that might work? I mean, we have to be willing. I mean, practicing medicine, part of practicing medicine is doing what's right for the patient and trying. Sometimes opening our minds to new things. So like he said, this is going to fly in the face of a lot of dogmatic beliefs about lungs and the way things are going and what they believe this is. So we have to be able to think outside the box sometimes, but hopefully we can get these messages to the right people. And I'm personally sending it to the CEO of my hospital, just because I want him to be aware of the new information, and then he can do with it what he will, right? But it doesn't hurt to try. So I would just encourage you guys to send it over to your, case unit managers or, your CEOs or whatever, and just be willing to take a step and to share the information with the people who need it.
Good. I agree. Yeah. You guys are awesome. Thank you.
Thank you guys for coming on with me.
Have a great night.
Yeah. Bye guys. Thank you.